The learning objectives today, we're going to review the original dissection classification systems and then identify their limitations with reference to arch dissections. We'll examine the controversy between radiologists and surgeons regarding arch dissections and try to understand where each one is coming from. Try to understand the potential adverse consequences resulting from using discrepant terminology. And finally, recommend a modified classification system to hopefully promote more effective communication. So first, let's begin with reviewing the thoracic aortic anatomy. We have the sagittal oblique reconstruction. And we have the ascending aorta, which extends from the aortic root to the beginning of the innominate artery. The transverse aortic arch from the innominate artery to the left subclavian artery, and we have the branching arch vessels. And then we have the descending thoracic aorta, which begins at the left subclavian artery down to the diaphragm. Now, in terms of the classification system of aortic dissections, the original classification began with Dr. Michael Bakey, as we're all familiar with the Bakey classification. And this is the original article from 1965, and his original diagram in which he depicts a type 1 dissection, which begins in the ascending aorta and extends down into the descending aorta, a type 2 dissection, which is confined to the ascending aorta, and a type 3 dissection, which is limited to the descending thoracic aorta, beginning just distal to the left subclavian artery. A few years later, a group from Stanford decided they wanted to revise the classification system and simplify it. And this is again an article, the original article with their original diagram, in which they simplified it to a two-letter classification system, A and B, in which A involves the ascending aorta and may or may not involve the descending aorta, and a type B dissection is limited to the descending thoracic aorta distal to the left subclavian artery. Here are real-life examples with the so-called candy cane view, or sagittal oblique. On the left, we see a type A dissection, and the Stanford classification is more commonly used, so we'll call it type A. Type A implies surgical management. That's the significance of the lettered classification. The reason it implies or it necessitates surgical management is they have a tendency to occlude the coronary arteries, rupture into the pericardium leading to tamponade, or even dissect into the aortic valve, causing fatal aortic insufficiency. However, in contrast to that, type B dissections generally only necessitate medical management because they usually do not dissect back retrograde toward the ascending aorta and the aortic root. But what about an arch dissection? Is that a type A or a type B? So here we have a reconstructed sagittal oblique image as well as axial imaging showing an arch dissection in which we can see the dissection flap just proximal to the left subclavian artery near the left common carotid artery. And on the axial image, we see it going into the aortic arch. Is this a type A or a type B dissection? So first we'll define an aortic arch dissection as an aortic dissection flap or an intramural hematoma which may or may not be confined to the arch between the innominate artery and the left subclavian artery. Here we have, courtesy of Annie Fraser, a nice drawing depicting an arch dissection. The intimal tear may be within the aortic arch with extension of the flap distally, or it may be in the descending thoracic aorta with proximal flap propagation into the aortic arch. Point being that the proximal extent of the intimal flap is within the aortic arch between the innominate arteries and the left subclavian artery. So now let's revisit the original dissection classification systems of the Bakey and the Stanford group. On the left, we can see their original diagram in the Bakey paper, in which they have a type 1, type 2, and type 3 dissection, but clearly they do not address an aortic arch dissection. Then we have the Stanford classification system, in which they simplify it to a type A and type B, but they don't include the aortic arch. So we performed an anonymous survey during last year's Roentgen-Ray meeting to try to see what the radiologic perspective is on this topic of aortic arch dissections. The audience was shown a cine clip of an arch dissection, and a paper survey was completed. It was a small sample size, but of the 14 respondents, approximately 80% believed that arch dissections are type A lesions, therefore implying surgical management. And we even broke it down into practitioners and residents, and the numbers were very similar. So we went back and did a literature review for radiologists. And these are two representative examples of what's out there in the literature. On the left side, we have what we're going to call ambiguous, where the literature says type A includes all dissections involving the ascending aorta. Type B involves the aorta distal to the left subclavian artery. Similar, it seems, to what was in the original Bakey and Stanford classifications and in their papers. Then we also have articles that clearly state an aortic arch dissection is a type A lesion. Type A dissections involve the ascending aorta or the aortic arch, while type B dissections involve the aorta distal to the origin of the left subclavian artery. However, the surgical literature says something entirely different. In 1979, the disciples of the original group from Stanford, headed up by Dr. Miller, wrote an article stating, from the standpoint, and I quote, "From the standpoint of pathophysiology and therapeutic strategy, we believe that aortic dissections should be classified according to the presence or absence of involvement of the ascending aorta, irrespective of the primary site of intimal entry. Therefore, the innominate artery should be the point of demarcation between a type A, or surgical lesion, and a type B, or medical management lesion." The rationale for this type of classification and management, similar to what we had initially mentioned, is that type A dissections, which require surgery, tend to cause coronary artery occlusion, rupture into the pericardium and may lead to tamponade, or dissect back into the aortic valve, resulting in potentially fatal aortic insufficiency. However, type B dissections, which generally can be managed medically, generally do not dissect proximally toward the ascending aorta. Therefore, the current surgical recommendations are that dissections originating proximal to the innominate artery, which means they involve the ascending aorta and may extend distally, are appropriately classified as type A dissections and require surgery. However, dissections originating at or distal to the innominate artery should be denoted as type B dissections, whether or not they involve one of the arch vessels. And intervention should be postponed or delayed for arch dissections, and medical management should be provided with antihypertensive agents unless there is end organ ischemia or patient instability. So we went back and investigated the prevalence and outcomes of arch dissections at our institution to see if our data will be concordant with what presumably the surgeons believe. And we found that there were 121 aortic dissections, acute aortic dissections, which approximately 9 of them, or 7%, involve the aortic arch the way we were defining it. Approximately 31% involve the ascending aorta, and 62% of which were in the descending aorta distal to the left subclavian artery. So there's approximately a 7% prevalence in our series. Then I looked at the outcomes. At the initial visit, all 9 aortic arch dissections were managed medically in terms of the area of the arch, and none of them dissected proximally back into the ascending aorta. 4 of these patients did require distal stenting, I think it was below the diaphragm, due to distal malperfusion, but none required stenting in the aortic arch or grafting in the ascending aorta. At 6-month follow-up, of those patients with aortic arch dissections, all of them were managed medically in the arch region, and again, none dissected proximally. 1 more patient had some renal malperfusion requiring descending aortic stenting. And finally, at 1-year follow-up, none of these patients required any intervention within the aortic arch or ascending aorta since they did not dissect proximally. 2 more patients had uncomplicated recovery and follow-up, and 2 patients were lost to follow-up. The adverse consequences that could potentially occur from miscommunication of aortic arch dissections, since the radiologist reports arch dissections as type A, the surgeons may consider arch dissections as type B. The radiologist's interpretation may imply a surgical lesion when it is usually not according to the surgeon, and confusion may occur as to proper treatment. Alternatively, there may be medical-legal ramifications in which the arch dissection, which is reported by the radiologist as a type A lesion, while the surgeon considers them as type B lesions, the surgeon may operate inappropriately and be liable for poor outcome if following the radiologist's recommendation, or they may be treated medically according to their protocol as being a type B lesion with a liability claim for a poor outcome. Therefore, our recommendation is to create a unified classification system in which type A dissections involve the ascending aorta, type B dissection with arch involvement, if it involves the arch and may extend distally but not proximally, and then we'll call a true type B dissection when it involves the aorta distal to the left subclavian artery. Some of the future concerns that we need to think about, though, is should we necessarily conform to our surgical colleagues? I believe that we should, especially since our small sample size of data seems to support that. But we still need to have more outcome studies with CTA imaging to support this, especially since most of the original surgical data stems from conventional angiography. Additionally, are there differences in outcome between intramural hematomas, penetrating atherosclerotic ulcers, and the rest of the acute aortic syndromes? In summary, aortic dissections are a small but important component of aortic dissections. Arch dissections are a small but important component of aortic dissections. The differences in surgical and radiologic terminology may lead to miscommunication and potential clinical harm. And therefore, referring to aortic dissections with proximal flap extension into the aortic arch as type B dissections with aortic arch involvement may provide the best compromise.